Good morning. Thank you so much for joining us on this Friday morning, the second and final day of the UQ RDI Conference 2021. My sincere thanks and congratulations to the conference organisers for both a thought-provoking and inspiring event. Whether you're attending the conference as an early career research academic like myself, or you're a development practitioner or policymaker, and wherever you are in the world, thank you so much to the conference organisers. I would like to respectfully acknowledge the Jagera and Turrbal traditional owners of the land on which this conference event is taking place today, and elders both past and present. I also acknowledge that we have a number of parties and participants joining us online today from other regions of Queensland and Australia. I would also like to acknowledge the traditional owners and custodians of those regions and lands and pay my respects to elders past, present, and emerging. I'm Claire Brolan, and I am privileged to be the community representative on the Australasian College of Emergency Medicine's Global Emergency Care Committee. It is my great pleasure to be chairing today's panel session, where we will discuss the preliminary findings of a piece of significant qualitative research that examined and continues to examine the perspectives and experiences of frontline health workers in the Pacific Island region, who are responding to the global health COVID-19 pandemic in their respective island nations and diverse and unique local contexts. The purpose of the research is to provide an impactful, robust evidence base to act as a conduit, if you will, for the key voices who are at the very heart of the COVID-19 response in the Pacific Island region, so as to inform multisectoral, multidisciplinary, culturally acceptable, gender-inclusive efforts to advance health system preparedness for future public health emergencies within the greater context of disaster preparedness and sustainable development planning and management in the Pacific Island region, and indeed the world. There is so much the world can learn from frontline healthcare workers and other key informants from the Pacific Island region in terms of innovation, resourcefulness, tenacity, and strategic clinical, as well as systems policy and planning responses to complex disasters and health emergencies, especially in remote geographic locations and in resource limited environments. And what is so invaluable about this research that we're presenting today is the incredible breadth and depth of voices and lived healthcare worker experiences that are captured and included in the study. So far, over 80 frontline health workers from the region have engaged in our research. And to those health workers, some I know are attending today, thank you. You do an extraordinary job, but you already did an amazing job, as we all know, at ACEM on the Global Emergency Care Committee, well before COVID-19 hit the Indo-Pacific and specifically Pacific Island region in 2020. Our project operates by way of a respectful partnership between the Public Health Division of the Pacific Community, or SPC, as well as with the committee members of the Global Emergency Care Committee of the Australasian College of Emergency Medicine, or ACEM for short. So ACEM is the peak body for emergency medicine in Australia and New Zealand, and is responsible for training emergency physicians and advancing professional standards in emergency medicine and care. But with the advent of COVID-19, our committee, along with ACEM's Global Emergency Care Desk and Global Emergency Care Network, have pivoted. I know, I love that word too. We pivoted and we have been enormously busy in the last 1.5 years working with Indo-Pacific colleagues to provide activities towards technical and policy assistance and support for EC clinicians, decision makers, policy makers in our local region responding to COVID-19. This included the development of COVID-19 emergency care response guidelines, specifically tailored to the Pacific context. The research project of focus in today's panel is led by Chief Investigator, Dr. Megan Cox, the formidable chair of ACEM's Global Emergency Care Committee. Megan's just a highly experienced emergency care physician affiliated with the Faculty of Medicine and Health at the University of Sydney. The multidisciplinary research team Otherwise comprises emergency care clinicians from Australia and Pacific Island countries and territories, along with public health qualitative researchers and development practitioners with experience in Pacific health systems, sustainable development, and global health policy and planning. We make for such a dynamic team. And the three panelists are all members of that research team. And I'd like to sincerely acknowledge our research team members who are online watching and no doubt deviously planning to hurl some curveball questions at the panel for Q&A. And Rob and Jared, we're ready and waiting. I'd also like to acknowledge Dr. Mangu Kendino, an emergency care physician at the Port Moresby General Hospital. She was supposed to be a panelist today, but very recently has given birth. Congratulations, Mangu. The research was originally funded by a grant from the ACEM Foundation and then through competitively awarded research consultancy funding from the World Health Organization. The WHO is very interested in our research, and we have a view to, touch wood, publish our preliminary findings in late 2021 in a special journal issue, and we'll keep you all posted. Now, it's with great delight that I introduce to you this morning's panelists. Our first panelist to present this morning will be Lisa Marie Herron. Lisa is ACEM's Senior Research Assistant on this project, and Lisa will provide an overview on our research project background and methods. Lisa has broad experience in health, medical, and social policy communications and advocacy, including more than 10 years in senior communications and advocacy roles with Australia's peak national cancer control organisations. Lisa also works in the Division of Health Promotion and Equity in the University of Queensland School of Public Health. I have known Lisa for 10 years now, and she is one of the most talented public health social researchers and strategic critical thinkers. I have the pleasure to know and work with and learn from you, Lisa. Thank you, and thank you for being part of our team. We look forward to hearing from you today. Following Lisa, Dr. Georgina Phillips will then present an overview of our research project findings so far. Georgina has worked at St Vincent's Hospital, Melbourne for more than 25 years with special interest in clinical excellence and research for patients with complex psychosocial issues. Since 1996, as an Australian volunteer doctor in Kiribati, Georgina has had ongoing involvement in emergency care capacity development in the Asia and Pacific region, including in Papua New Guinea, Solomon Islands, Kiribati, Fiji, Timor-Leste, and Myanmar. Georgina is a past chair of the Australasian College of Emergency Medicine's Global Emergency Care Committee and current board member of the ACEM Foundation. She serves also as a trustee of the Primary Trauma Care Foundation and member of the Committee of Management of the St Vincent's Pacific Health Fund. Georgina, you are a powerhouse, and it's wonderful to have you on our panel today. Thank you so much for your time. And last, but in no way least, our third and final panelist, Dr. Deepak Sharma. Dr. Sharma will then reflect on the emerging project findings as presented by Dr. Georgina Phillips, as well as on his own ongoing experiences as an emergency care physician or EC physician, in case our panelists use that acronym this morning, responding to COVID-19 surge events in Fiji at present. Deepak, I know that you're currently intensively responding to the COVID surge in that country, and we are so grateful that you were here this morning and for your sharing of wisdom and knowledge. Thank you so much. Dr. Deepak Sharma is an emergency consultant at the CWM Hospital in Suva. Deepak completed his Masters of Medicine in Emergency Medicine in 2018 and was a recipient of the prestigious Mika A. Koi Award and funded by the Australasian College of Emergency Medicine Foundation. This award is presented to the highest performing participant in Fiji's Masters of Emergency Medicine program. Dr. Sharma is a committee member of the Fiji National COVID-19 Task Force and the CWM Hospital Task Force for COVID-19. Again, Deepak, thank you. We're so honoured you're on our panel this morning and can't wait to hear from you. Okay, enough from me. Each of our panelists will speak for around 10 minutes, which will be followed by a Q&A session with you, our audience. Okay, over to you, Lisa, on project background and methods.
Thank you, Claire. Right. Thank you so much. Good morning, everyone. As Claire has already introduced me, I'm a research assistant who was contracted by ACEM earlier this year to support this research project and develop reports and academic papers. As Claire has explained, this project was born of the existing partnership between ACEM and SPC, who together identified an urgent need to examine the Pacific emergency care response to COVID-19. The study was designed to explore the lived experience of clinicians and stakeholders at the forefront of the emergency care response to COVID across the Pacific, using rapid, prospective, qualitative research methods. We deliberately used strengths-based appreciative inquiry to give voice to clinicians and other stakeholders in the region. Because the data collection occurred over a 6-month period, we also incorporated components of a participatory action research with the dual aim of supporting actions to improve and enhance local responses and increase understanding in both researchers and participants about the nature of the evolving pandemic response. We gathered data from emergency care clinicians and other stakeholders across the Pacific in 3 phases via online support forums, in-depth interviews with key informants, and focus group discussions. This flowchart illustrates the complete data collection, processing and analysis process, but I'll break it down and explain each step. It's a little bit overwhelming in that format. So as I mentioned, the research was conducted in 3 phases. Phase 1 of the study began in March last year when the COVID-19 situation escalated across the world. ACEM promptly began convening online support forums for emergency care clinicians in the Pacific region. These forums, facilitated via Zoom, began in March last year and were offered fortnightly until July and then monthly since. Invitations to participate were widely disseminated to clinicians and stakeholders in the Pacific region via regional contacts and networks. While the primary purpose was support and information sharing, the potential to capture data for research was recognised, and so participants were informed verbally and in writing that the forum was being recorded and that data, including comments in the chat function, would be anonymously used in research. They were also advised of their right to contact the researchers if they did not want their data to be used. Forum participants included key emergency care clinicians and other healthcare workers, program managers and policymakers, as well as representatives from the WHO Representative Office of the South Pacific, and ACEM fellows with Pacific experience and professional connections with emergency care colleagues throughout the region. Participation was open to all with no exclusion criteria. For this research project, we analysed data from the 13 forums between March and October last year. In total, there were more than 80 individuals from 15 different countries and territories actively contributing by sharing their experiences or commenting during the forums in one or more of those sessions. The second phase, data collection, involved semi-structured, in-depth interviews with informants across the Pacific region, again conducted and recorded using Zoom. These interviewees were purposefully selected because of their experience leading and or coordinating emergency care during the COVID-19 pandemic. There was no minimum sample size, as our aim was to have representation across disciplines, particularly a combination of emergency medicine physicians and nurse leaders, and across specific countries and territories and genders. As you may have noticed on the slide, there were 2 parts to phase A. To phase 2, sorry. 2A was an interview of 7 participants to inform a report to the WHO, with a focus on ethical issues in preparedness for and responses to COVID-19. And to meet WHO ethics requirements, the informants were asked to respond as an official representation of their employing health service of organisation. We also undertook a second part of those interviews focused on more personal experiences and views, and those responses were anonymous. Phase 2B was some further individual interviews to gather more data for the broader research project. In total, we've now interviewed 12 informants from 9 different countries across the region. Phase 3 is the most recent phase of data collection involving focus group discussions using Zoom with emergency care stakeholders from recognised geographical regions of the Pacific, Melanesia, Micronesia and Polynesia. Again, participants were recruited opportunistically and purposefully through ACEM, SPC and regional networks, with a particular focus this time on engaging women, nurses, non-physician healthcare workers and other clinical and non-clinical stakeholders. But focus group participation was open to all interested stakeholders without exclusion criteria. All of this collected data were de-identified to protect participants' anonymity. Moving on to the data collection and analysis methods. In the online support forums, discussion at each forum was framed using the 4 emergency care components: staff, supplies, systems and space, with an emphasis on one component in each session. Research team members facilitated and encouraged open discussion among participants and pursued any issues raised. The frequency of those forums, fortnightly for the first few months of last year, meant discussion could be adapted according to participant needs, new issues arising, or pandemic events in particular countries. For the phase 2 interviews conducted by Zoom, these were conducted by a research assistant and one other member of the research team. We developed a semi-structured interview guide using the 5 Pacific emergency care building blocks to structure questioning, and also incorporating elements of feminist, safety science, and medical ethics theoretical frameworks. The guide was developed collaboratively by the entire research team, which meant we benefited from the knowledge and experiences of the multidisciplinary and multinational group. While none of our bespoke data collection tools were piloted due to timelines and the real-life constraints of Pacific regional research, the interview questions were adapted iteratively according to participant responses. For example, if there was an apparent lack of clarity or lack of relevance of a particular question. So while the questions were structured to obtain the data we needed, we also aimed for a naturalistic conversation with open-ended questions to ensure the informants could share the experiences of most importance to them. For the phase 3 focus groups, a discussion guide was developed drawing on core elements of the individual interview guide, but more appropriate to group discussion and with the added emphasis on gender. Given the gendered impact of the pandemic, we used feminist theory in our data collection and analysis to ensure our research represented the experience and voices of women at the frontline and identified gender-specific dimensions of the COVID-19 emergency care response. Again, this guide was semi-structured and intended to be just a guide. The research team members who facilitated each session iteratively refined questions for clarity or in response to the discussion taking place, and encouraged discussion of issues that were raised by participants. Recordings of 13 online support forums containing over 18 hours of discussion, 12 in-depth interviews and 3 focus group discussions were transcribed verbatim and subsequently de-identified. This massive amount of data was entered into NVivo for preliminary coding. We used a hybrid deductive and inductive thematic analysis approach. Deductive codes were determined by our research objectives and the analytical frameworks, including the Pacific emergency care building blocks, and inductive codes were added where they expanded on an a priority code or described a new theme. Excuse me. As this study was specifically designed to explore ethical issues and tensions through the lens of Pacific emergency care clinicians, findings also were developed in relation to tenets of ethical decision-making, such as beneficence and justice. Due to the volume of data related to each of the 5 building blocks and other thematic topics, and to enhance inter-rater reliability, we divided the next stage of analysis amongst the research team members. Pairs of members were allocated different building blocks and themes and tasked with reviewing the key barriers and enablers, identifying sub-themes and highlighting ethical and operational issues. We then met in a virtual workshop at which each pair presented findings with exemplifying quotes from the data, and we collectively verified and agreed themes through discussion, data triangulation, and reference to our research questions. As Claire has explained, the research team comprised emergency care clinicians from Australia and the Pacific, along with qualitative researchers and development practitioners with experience in Pacific health systems. A strength of our study design and approach was that each member was actively engaged in each aspect and phase of the research, including data collection and analysis. Researchers drew on their Pacific context expertise, their professional collegial networks, and their own personal experiences as clinicians and care providers during the pandemic. Strong Pacific region representation in the research team increased the validity, credibility, and acceptability of our project for participants. It also addressed issues of respect, reciprocity, and research collaboration in the region. As mentioned before, one of the original aims of ACEM's online support forums was to provide a safe space for clinicians to share experiences and ethical concerns and seek advice and mentorship. While collecting rich research data, our collaborative, reflexive approach to this research also provided participants with collegial support and opportunities to reflect. Our participants have been extraordinarily honest and candid and provided rich and insightful descriptions of the challenges and strengths and weaknesses of emergency care responses. It has been a privilege to hear them and play a part in identifying the important learnings and developing recommendations that will improve the preparedness of Pacific countries and territories for future surges or other public health emergencies. I'll now hand over to Georgina to discuss some of the findings.
Hi, everybody. I'm just trying to work out how to do my camera. Okay, hi. Thank you, Lisa, and thanks, Claire. I'm got the great honour of being able to talk about our preliminary results in 10 minutes, which is quite a task because, as you can imagine, we've collected an enormous amount of data, very rich, very deep, very illuminative. And so I'll just be able to give you a taster in our session today, and hopefully it'll stimulate some questions. As Lisa has outlined, we analysed the data in several different ways. We used all of that data to look at the key themes that emerged, and we identified 6 key themes, which I can talk about later in questions if you're interested. And then part of our research, as it was funded by the WHO, was to look at the responses and the experience within an ethical framework using the medical ethical principles of autonomy, beneficence, non-maleficence, and justice. For the purposes of this session today, I'm going to be focusing on the emergency care system building blocks, which was a framework that we used to look at challenges and barriers and strengths and enablers in the response across the region. And the building blocks that we're using are derived from the WHO health system building blocks, which some of you might be familiar with, which are outlined in that first column with the colours there of health workforce, medical products, vaccines, technologies, information, service delivery, financing, leadership and governance. And through a process that has been a very large piece of research in the past, we've adapted those building blocks for the Pacific context and had it agreed upon through a very large consensus process to be tweaking them slightly for the Pacific and for emergency care, focusing on human workforce and training, infrastructure and equipment, because that's so critical to the ability to deliver emergency care, data, service delivery we tweaked to processes, meaning things like triage, patient flow, these sorts of clinical guidelines, these sorts of processes of care, and combined financing and leadership and governance into the overarching building block of leadership and governance. And I'm going to be talking about our findings within that framework. And then I'll be finishing by just highlighting some of the key lessons learned and recommendations so far. It's an evolving process. And then briefly mentioning our pivot with our ongoing research collection to be focusing a bit more on gender, the gendered experience. So let's just whiz through the results and using our building block framework. And the first building block was the human resources and training. And here are some of the lessons that we learned with a few quotes. There's a lot there. The key message really, and this was a really strong finding before even getting to the content, was that the great bulk of our data was about the staff and the staff experience, and that whole concept of looking after staff and the training of staff and the preparation of staff. So under that building block was an enormous bulk of our data. And I think the key message is that emergency care staff are crucial assets in a pandemic response. Their engagement, education, support, collaboration, transparency and fairness are key issues that came up and will maximise their work. And if those things aren't in place, then there's problems. And so initially it was clear that there was fear and panic. Those things could be mitigated through concepts of training, transparency, education, communication, practice sessions with simulation. All of these things led to confidence and readiness. The staff needed to feel engaged and protected. And one of the messages that came out was this issue of fairness and reciprocity. So the first quote, the staff, I think, are potentially one of our biggest problems. They're really unhappy, they're frightened, they haven't been engaged with. And the other quote, the staff, we love our job, but we have issues like with our leaders and our salaries and all of this. They're trying to minimise our overtime. So there's a tension, I suppose, of a very strong work ethic and dedication to service from emergency care staff, but also a feeling of being at the front line, being exposed and needing protection and needing to be given the empowerment and education and respect to enable them to keep doing their work. So that many very interesting concepts coming out of the human resources and training building block. The next building block was infrastructure and equipment. And as you can imagine, in the pandemic, the issue of PPE was one of the really big issues, the personal protective equipment that came up very quickly in all of the data. But I think the main message from the infrastructure and equipment was that resource limitations in this area, not just in PPE, but in the physical buildings of emergency departments and hospitals, those limitations really impacted on safety. So having plenty of PPE, enough space, and the ability to separate the potentially infectious patients from other patients was really critical, and focusing on doing the basics well. There was some pressure, or some people described a lot of pressure, to elevate their levels of care beyond what they would normally do in their Pacific Island countries, and that really revolved around the issue of ventilators. That was a very interesting concept. People, I think the lay and perhaps the leaders of countries were very keen to get this idea of ventilators. We need plenty of ventilators for sick people, but many Pacific Island countries don't have that capacity. And there was a tension there about safety to do things that they weren't comfortable with. So some of those quotes just illustrate those concepts in terms of intensive care. I don't think we'll be able to do that here. We don't have ventilators. We don't have a lot of stuff here. And the tension of the PPE, that was a key concept to staff feeling safe and able to do their job. We do have major issue with low PPE supplies due to closed borders. We've ordered PPE and some donations are on the way, but how do we get it there? And that tension between the screening and the isolation and trying to separate and what the criteria were for screening and having enough space and good design. Our facilities were not ready in terms of preparation. We've decided that we'll handle our COVID patients somewhere outside of the hospital, but even finding those spaces and setting them up and having the right equipment and the right staff for those spaces was an ongoing tension. We combined the building blocks of processes and data, and most of these key learnings are about processes, and the lack of information about data is telling in itself. Collection of health information at the pointy end of the hospital in the emergency department is extremely limited across the region. Our clinicians are overwhelmed and exhausted in providing care and setting up their systems, and so the collection and analysis of data is unfortunately not a priority. And so the lack of data has huge implications because if you don't know what you're doing, then you can't analyse it and improve it. So lack of data is telling in itself. But the lessons about processes really, again, the main messages are that the pre-existing emergency care processes, such as having an effective triage system, having patient flow systems, enabled a much stronger response in the first instance. So if those things already existed, then they're able to step up and pivot for a pandemic response. Having guidelines and locally relevant screening and testing criteria were really important and needed to be prepared early. So this quote down here, before COVID, we didn't have any sort of patient flow system if you work here. So it's like any Tom, Dick and Harry will just come in. And as you can imagine in a pandemic, if you don't have a way of managing crowding and flow and triaging, then that escalates to be a really critical problem. And so it triggered a whole lot of reflection and action to get guidelines in place. Up the top, before they send a case or refer a case, whoever is referring will update the ED first. Look, we're sending this case over to you guys. And there was a process, but we don't really have these things as a national guideline. I've created one because at the end of the day, you know, we're the ones responsible. So that, that leadership from the emergency care clinicians to get things happening. The last building block, leadership and governance. Already there's the leadership of the emergency care clinicians was emerging through the other building blocks, but this was very clear that emergency care clinicians, doctors and nurses, have expertise in managing crowds and surges and pandemic responses because of their training and their flexibility. Many of them have experience in disasters in the region and already had that pre-existing knowledge and networks and expertise, and they also work in teams. So they naturally have the leadership and have the capability to take leadership roles in this pandemic context, and that definitely emerged out of the data. The best responses happened when the government engaged the clinicians in a collaborative approach, and there was multidisciplinary teamwork. And the partners in the region, colleagues from different Pacific Island countries, but also partners like ACEM and other expert partners from the WHO, really assisted to build local knowledge and aid in helping them work through strategies and troubleshoot issues. So I like that middle quote: whenever we're not sure about anything, we call up any of the emergency physicians and we ask what's been done, and they send us things and they offer advice, and it's like a lifeline. And that was definitely one of the very wonderful things that came out of the data, this sense of solidarity across the region. I've probably talked for over my 10 minutes, so I'm going to get to the last point, which was just the preliminary recommendations that came up from the first phase of our data analysis. And there were three kind of key recommendations that came up. And the one was about, the ethical challenges, addressing them early, being prepared for them. So that proactive approach and being very context specific in the guidelines and the recommendations that for clinical care and also for systems response. Having a safety culture was really important, and being prepared and supporting staff who are experiencing moral injury because through their frontline exposure to illness and sadness and death or risk of death. The second recommendation was prepare for, develop capacity to respond to the public health emergency surges. So in getting the emergency care clinicians early on, who are experts in this area, involving them early. That tension between maintaining existing services and routine care, as well as managing the response. Having that whole of health system approach, involving public health and clinical services together, which is essential for the integrated health system, and using partners for support as much as possible. And the final recommendation is really a key message, which is routine emergency care. If that is strengthened and built in pre-pandemic times, then that will definitely enable countries and health systems to be able to step up and respond appropriately in surge events. So emergency care is essential to the health system and will significantly improve pandemic responses. There are WHO resources to build emergency care systems with paying attention to those building blocks. Risks exist already in the Pacific Islands countries of overcrowding, and that is a serious infection and prevention control risk. And so there needs to be attention to improving patient flow, redesigning clinical space, and getting access to data will help inform future pandemic responses. And as Claire and Lisa has alluded to, the data collection is ongoing, and we're in our extended data collection, we're focusing on women's experience and trying to explore gender differences in the experience of the frontline workers and all emergency care stakeholders. So we're really delving deep, getting a wonderful, rich data, and we hope to be able to expand some of these findings and share the experience very broadly. And I'll hand over to Deepak.
Hello everybody, Bula Vinaka from Fiji. Sorry, I don't have a slideshow, so you'll just be listening to me. Yes, just like Dr. Georgina, Claire and Lisa have alluded to earlier, You all do know Fiji is battling its second wave of COVID-19 with the Delta variant. Challenging times for us. Every day we encounter new challenges, but we're taking it one day at a time. For the Fiji emergency care system, prior to 2012, we didn't really have a developed program, and then we're a very young specialty. Having said that, we have encountered several challenges and we've come out strong and we've been recognized for that. And this COVID-19 was actually, I guess, a silver lining in that way that the strengths of emergency care physicians in Fiji came to light. And our ability to work in different facets of controlling or containing and assisting in the care of the patients. Yeah, we were able to successfully contain the first wave last year. We started our vaccination program, and then the Delta variant hit us this year, and we're still in the middle of it. What I can say is for us, especially from the hospital where I work in the Central Division, we had these Zoom sessions and the webinars that we had with the ACEM was actually definitely one of the lifelines, because at times when we would get stuck or we had a very strong relationship with our mentors, which were coming from ACEM, and they would be with us in our facilities for several times throughout the year. And then with the pandemic, given the borders were closed, we were not really able to see them in person, but joining them in the webinars, talking to them gave us that hope. And it also allowed us to share ideas and see whether what we were doing as emergency clinicians in our facility was on the right track, or were there areas for us to improve on. The good things were that I guess we had a measles outbreak in 2019 at the end, prior to COVID-19. And so the idea of isolation and separation of the patients was already in play. Come 2020, once the first cases were there, together with the emergency department, the whole of hospital approach, and then the whole of the healthcare approach with public health, there was the development of our national task force, and emergency medicine was on it as well, and in the hospital task force as well. And we developed several things. So looking in terms of the emergency care health system building blocks, in terms of looking at human resources and training, there was pathways for training of healthcare workers on IPC measures, safe donning, safe doffing, and then the care and management of COVID-19 patients when they would arrive, or when we would have cases. This is looking at pre-March 2020. And I must say, given that we had that training, and once the cases came down, though there was refreshers available, it made it a bit easier in 2021 when the cases started escalating, that we didn't have to redevelop teams. Our COVID and non-COVID teams had already been identified, and these were just activated again. So it made it a smoother transition. In terms of looking at infrastructure and equipment, yes, as with every other country, we did have our concerns of PPEs, ventilator, airvo. Fiji, and in terms of our emergency departments, we actually do have the capability of providing ventilation and other care. So the ability to get these equipment in case of surges was the area that we were looking into, and unfortunately it did come along later in the year. Then PPEs, and then we had to sustain this separation. So initially, having a separate area for isolation was one of the concerns, and then this got developed, and for our ED in CWM, we have a separate room that's totally our isolation area. So anyone who's at risk, this is, I'm talking about 2020, where we had the at-risk population, or they met the risk factors, then they would be directed to the isolation area. In 2021, given that we have community transmission between the Suva and the Swari corridor, so everybody is labeled as at risk until proven otherwise. So they're all directed to that isolation area before they come into our clean ED, so to speak, or they're directed towards our COVID side of the facility. In terms of processes, yes, this was another important area, and given that the emergency department is the the entry into the hospital, we had to be part of the decision making and had our voices heard, which was very good. And the processes and the reevaluation of them and the fine tuning of it was directed from the ED perspective, which was quite good. And so apart from having the task force meetings, there's always a daily clinical Zoom where all the clinicians within the hospital meet and they discuss clinical issues and the logistics and non-clinical issues. And ED is always giving up its issues that can need to be looked into to facilitate patient care, especially this year around. And then leadership and governance. It's actually quite heartwarming to see that this year around, when our challenges are far more than what we've had last year, the clinicians, the consultants and the ED leaders are taking a challenge, and they're actually working in different facets. I know some of my colleagues, they're in our FEMAT, our Fiji Emergency Medical Assistant team, and they're providing emergency care there. They're providing oversight and coordinating. A few of other clinicians are looking after our emergency department within the hospital. I, for one, am seconded to our divisional command center, so we're providing care over there and looking at logistics and looking after other facilities. So leadership has really shown and flourished in the emergency department, given this second wave of ours. And it's also very important because initially, earlier on last year, when the first cases were coming about in the other countries, our junior staff, our nursing colleagues, where there was the fear of the unknown. So the leaders took up the challenge and showed that with good knowledge and access to the correct information, you could actually work and look after such patients, take care of these patients, and have that appropriate system of not being so fearful all the time. And so this really provided a good way that our junior staff were able to look at and model our behavior, that not be so fearful, but have access to the correct information and be part of the team and work together as a team. I guess I'd stop over there. Yes, we had those challenges last year. We managed to work on them successfully, containing them, but then this year our challenges are quite a lot. We're going through it day by day, and yes, the emergency department, the emergency care doctors, nurses, colleagues are all working daily, doing our level best, and we're hoping that we will be able to see light at the end of the tunnel sometime soon.
Deepak, thank you so much. And also thank you, Georgina and Lisa. We've already got a question from our audience, which I thought I might lead with. And the question is around contingency planning for pandemic response and how comprehensive and I guess multi-sectoral that should be beyond ministries of health, beyond health services and systems. And should this type of comprehensive planning with national level impact have regular sort of stress testing? Georgina, I might get you to start in terms of responding, and I'm sure Deepak, you will have some thoughts as well. Thanks, Georgina.
Oh, there's no doubt that through our data that the systems that were most functional were ones where there was multi-sectoral involvement, involving clinicians, public health people, and other relevant stakeholders, I suppose, perhaps, you know, first responders like police or fire and government ministry people. And definitely countries that, and this is quite common in the Pacific, countries that have already experienced disasters and surge events already had those relationships pre-existing. It's fair to say there probably weren't comprehensive plans, or that this has been a trigger to develop comprehensive plans, but they'd certainly been tested by, you know, as Deepak's already said, for example, a measles outbreak, or in other parts of the Pacific, other surge events where there's been really productive work across sectors, but where the clinicians, the emergency care clinicians, have often been taken the lead. And I'm thinking particularly in disaster response planning. And I suppose this research really demonstrates that and is a plea for recognition of clinicians as key people in these types of teams in preparation and planning. I don't know if you've got anything to add to that, Deepak.
No, I agree with you, Dr. Georgina. Yes, it needs to be like a group of people that are both clinicians, non-clinicians. People are able to do the logistics, because as healthcare providers, we really can't do everything. Our area of expertise is providing healthcare, but we sure do need people to look at the other areas, and it's the teamwork that makes it quite good. Having regular stress tests, I guess for us in the Pacific, you don't really have to wait for a stress test. There's always an epidemic or something around the corner. If it's not an epidemic, it's a cyclone that's going to come in November or June or January. So we're already testing our systems on a regular basis. But yeah, it's that multi-agency collaboration that does work, and it makes a bigger difference. The doctors' voices heard is also important, because they're the ones on the front line, and they deal with it at the ground zero. Yeah, so it makes a better system and approach.
And it seems to me, though, Deepak, through your own work, that you know you're not only providing clinical supports, much needed clinical supports, but you're on the national task force. So you're also feeding that frontline clinical experience, lived experience and information back to the multi-sectoral policymakers to inform their policy and planning. So it seems to me that you have a really important role to play in terms of providing evidence for policy and planning and resource allocation.
Yes, actually, our task force, yes, definitely. But yeah, we also have in our national task force, we have quite other doctors who are also more experienced than myself, and they are also able to give more insight. But yeah, it helps us devise the processes and keep adapting it to the new challenges that are coming, and also the SOPs or the operating procedures that are approved through the task force then go to the other agencies that are also other pillars that are part of the bigger committee, and so they given their input in the areas that they can help out on.
And Georgina, back to you. Thanks, Deepak. What has been the most interesting or surprising finding or findings? I can imagine there are so many that have emerged from the data so far, in your view.
Thanks, Claire. I think it's perhaps not surprising, but it's always wonderful, is the incredible dedication and service ethos. I think that's come out of all of the data across the board, and that resilience and tenacity, as you mentioned right at the start, of clinicians. There was this, of course, there was fear and anxiety in the early stages, but equal to that was this very strong sense that we are here for our people, and we must step up, and the fabulous leadership of some of our colleagues in the region, of even in great uncertainty, putting themselves forward, putting their hands up and leading care and response, even when there was uncertainty and risk. So that and often, without appropriate recognition, financial recognition or other supports in place, that we might expect in our context in Australia and New Zealand, Pacific Islanders and other people in the region often give incredible service without any of that recognition. So that came through really strongly. And also just the creativity and resilience of unique responses across the region. Really interesting use of cultural strengths, I suppose, to adapt for using places for screening and triage, or sharing information, or making collaborative decisions you know, using the cultural strengths of individual places. That was really interesting to learn about. I don't want to kind of name names, I suppose, but, you know, there was just some really interesting use of traditional places for screening or for sharing information. And
okay, thank you. Thanks, Georgie. Is there any more questions from the audience? I've been told very politely if we could please wrap up in a couple of minutes' time because there's a short turnaround until the next session at 10:15. I can't seem to see anything. Let me see.
There's a couple in the Q&A, Claire.
Oh, here's a few questions. Yes, I see. Question for Deepak. Has the current context community transition surge forced you to change your policies and processes? How have you had to adapt? I think you answered that one in a way, in the sense that you were able to build on previous policy and plans that you had developed from 2020. But is there something you want to add there?
Yeah, so yeah, we've definitely built on from where we started from last year. But yeah, given that we've got that community transmission and our high number of cases, and anticipating basically what we've known from data from abroad, that, you know, the 80% will be asymptomatic, 20 and 50, and the surge capacity, we've moved into what we've now called our mitigation approach rather than containment. And so previously, we used to have the ability to hold all our positive cases in isolation facilities, but now our approach has sort of changed to identify those who are more at risk based on the risk factors, which is available in our local adult management guidelines, and then identifying the severe ones that need to come through the emergency department. And our emergency department at CWM actually has evolved in that way that we're sort of like an intermediate facility, so to speak, or area, where if there's an unknown case or so, we sort of become the area that sort of like assists in sorting it out, whether they fall down the COVID arm or the non-COVID arm, or whether they've got not COVID but unwell for some other reason. And so yeah, our systems and processes have actually evolved more recently over the past few weeks, given our surge. But yeah, it's in line with what our ministry is aiming at, given our increasing numbers.
Thanks, Deepak. It's the situation is unfolding and it's so dynamic, and I can appreciate that it's an iterative approach. I'm going to have to wrap up there. I would like again to thank all panelists, Dr. Deepak Sharma, Dr. Georgina Phillips, and the wonderful Lisa Marie Herron, for your time and sharing your knowledge and experience today. It's a great pleasure to be with you on this particular research project. I'd also like to acknowledge my fellow researchers who are online today, Rob Mitchell, Gerard O'Reilly. Thank you so much for all that you do as well, and to the doctors, nurses and other healthcare workers at the very front line at the Indo-Pacific region. We salute you, and please get in touch with the Australasian College of Emergency Medicine if you need further supports. Okay, with that, thank you all so much, and I hope you all enjoy the rest of the conference. Take care. Bye for now.